Good afternoon, good evening again, ministers, delegates, ladies and gentlemen, colleagues, friends. It's so great to be here for this Communications for Health side event. My name is Angela Pratt. I'm the Director of the RD's office as well as Director of Communications and External Relations at WHO Western Pacific Region, and I cannot tell you how happy I am to see you all here today and to be your moderator for this event. To meet the vast range of current and future challenges that our region faces, for the future, our shared strategic vision adopted by Member States a couple of years ago at this committee called for greater use of strategic communications, what we call Communications for Health, or C4H. And the reason for this is simple. The modern world demands more communication in public health, for example, in response to the COVID-19 infodemic. But it also calls for smarter use of communication in public health. To be effective, that is to create impact with our communications, through our communications. We need to be informed by data, by evidence and theory, and most importantly, we need to be informed by and working with the people and communities that we serve. So during today's event, we want to tell you about our work so far to build a program of technical work at WHO that delivers on this ambition, and we hope inspire you to join us as we work towards scaling up this approach in the region in the future. In all of this, we are incredibly fortunate to have the very, very strong support of our Regional Director, Dr. Takeshi Kasai, and it is my great pleasure to invite him to deliver some opening remarks now. Adi, over to you.
Thank you very much, Angela. Distinguished delegates, ladies and gentlemen, good morning and good afternoon, good evening. And thank you for joining the side event on Communication for Health, or what we call C4H today, as Angela mentions. We have long known that communication is important for the public health, but during the COVID-19 pandemic, good health communication has been more important than ever before. We realize that. And not only for informing communities, but also for empowering them to take the actions that are needed to protect their health. But while we know communication is important, but up till now, it has not really been recognized communications as the technical expertise in public health. And this is what we hope to start challenging ourselves and changing through the Communication for Health approach. As Angela said, Communication for Health means basing our work on data and evidence and listening to our audience and putting their voices at the center. And it also means that we have to evaluate our effectiveness on what we do and learning from what the result tells us in order to continue to improve. And it means making investment in building capacity and strengthening the evidence base for Communication for Health. Last December, we brought member states together to discuss how we can work together to scale up Communication for Health in the region. And that first meeting, I was very much impressed that everybody recognized that the Communication for Health is crucial for making our region the healthiest and safest. And that meeting was an important milestone in our efforts to establishing the communications as WHO technical program. And I'm really pleased that we're taking another step today by showcasing some of the Communication for Health work we're doing in countries around the region during this RCM. We still have some way to go, I have to admit, to establish the Communication for Health as a fully fledged technical program. But we are looking forward to working with you as we strengthen and scale up this approach. Thank you very much, Angela.
Thank you so much, Adi. So in a moment, we're going to hear about some examples of our work using the C4H approach in countries around the region. But before we do that, we want to play you a very short video which explains a little bit more about what we mean by the C4H approach. So let's take a look at that video now, please. Recognizing that knowledge, attitudes, and social norms are key determinants of health, the C4H approach harnesses insights from social and behavioural sciences
to inform and change attitudes and behaviours, with the aim of contributing to improved health outcomes. To fully leverage the power of communication as a tool to improve health, WHO is working with our member states and partners to scale up C4H in the Western Pacific region. C4H is all about impact. C4H is informed by evidence, data and theory, measurable, planned rather than ad hoc, audience and people-centred, collaborative, drawing on the skills and efforts of a broad range of experts, partners and stakeholders, and it's targeted. C4H interventions have specific, realistic and measurable health objectives. C4H works with different audiences using a range of tools different channels to achieve these health outcomes, with the overarching goal of making the Western Pacific region the healthiest and safest region in the world. Harnessing the power of communications also means going beyond the data and statistics and connecting with people on a human level. Communicating with impact means connecting with people's hearts, not only their heads. People's brains are hardwired, not to remember what they are told, but to remember how they are made to feel. One way of making people feel is telling great stories. Stories have the power to teach, to persuade, and to be remembered, cutting through some of the noise of the digital age. That's why storytelling, focused on people, is at the heart of the C4H approach. Just like medicines and vaccines, C4H is a tool for contributing to better health outcomes. By targeting our efforts, drawing on data and evidence, creating an emotional connection with our audiences, and focusing on impact, C4H can help to deliver better health for individuals, communities, and societies. By working together to scale up C4H, we can help make the Western Pacific region the healthiest and safest region in the world.
So let's now look at some examples of how we're applying this approach with countries in the region. First, we're going to go to Malaysia and hear about how the C4H approach has been used to create strategic, targeted, and inclusive communications for COVID-19. The work of the Malaysian Ministry of Health and WHO country team is a really terrific example of how data and listening can be used to shape communication strategies, address misinformation, particularly important, as we all know, in the context of COVID-19, and create messages that resonate with the people that we need to hear and act upon those messages. So before I introduce the Malaysian Minister for Health, who we are very privileged to be joined by here today, let's look at another very short video explaining our work in Malaysia using the C4H approach.
Malaysia has a diverse population. This diversity has contributed to the country's rich culture, but presents a challenge when trying to communicate relevant public health advice. When COVID-19 hit Malaysia, it immediately became clear that life-saving information needed to reach everyone who calls Malaysia home. To achieve this, WHO supported Malaysian health authorities in setting up communications for health strategies that involved two-way communication with the public. Information on community perceptions was gathered through surveys and focus group discussions, identifying the knowledge gaps of specific groups and enabling a quick response to rumors and misinformation. Mechanisms for social listening helped us analyze online conversational trends to understand the shifting thoughts, feelings, and behaviors of the community. Local organizations were engaged to work directly with communities, going door to door, not just asking questions, but listening and addressing concerns. Community and religious leaders were mobilized to combat stigma and discrimination and ensure that all voices, including vulnerable and marginalized populations, are integrated into the response. WHO and the Ministry of Health has turned this information into actionable intelligence, targeting communications to address the needs and concerns of different audiences. Collecting and triangulating multi-source data helped us identify misperceptions, which was crucial when nudging youth to modify behavior and protect their health. We continuously adjusted our messaging and developed outreach materials in multiple languages to reach all pockets of society and support adherence to public health and social measures. Based on insights from social listening, we designed campaigns to reduce vaccine hesitancy and promote uptake. We've listened, learned, and grounded decision-making in evidence while treating data not just as numbers, but as people with valid fears, concerns, questions, and solutions.
So, as I mentioned, we are thrilled to be joined here in Himeji this week by the Honourable Khairi Jamaluddin, who is Malaysia's Minister for Health, and it is my pleasure to introduce him now. Minister, I know that you are passionate about the importance of data. We've heard you speak about that in several of your interventions during the RCM this week. Can you tell us a little bit more about what drives that passion and why it is important in the field of communication?
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon to everyone. First of all, I'd like to thank both Dr. Pratt and RD for allowing me to share a little bit about what's happening in Malaysia on the C4H. But before that, I just wanted to echo what RD said, that communication is a public health intervention. And it is actually a technical public health discipline. And we hope that we can together grow that discipline into something that is more professional and more technically sound. I have a short deck presentation that I'd like to share with everyone. If we can share this, thank you. Next. Based on C4H principles, informed by data, measurable, planned, people-centered, I thought I would also just modify it slightly to the experience in Malaysia over the last 1.5 years. The first thing is to communicate with substance. Many people look at communication as just spin or communication and often forget that there has to be something to communicate or something to spin. You can't spin thin air. Secondly is to actively drive the narrative, because information and data in a vacuum can be driven by people with other agenda. Third, of course, is to use the insights to create behavioral change. Fourth, of course, is the heart of it, as mentioned just now, which is to get local, to get personal. Data speaks to the brain, but it doesn't speak to the heart. So how do you distill that data to speak to the heart? And more on heart is about building trust via personal accountability. Because if people don't trust you or the authority, the health ministry, then there's not much the data can do for you, because there's a trust deficit. Next. So we start with the most granular part of the data that we share in Malaysia. We share on a daily basis very, very granular data sets on what is known as GitHub. This is a global repository for data. And it's anonymized, individual level case and death data. So you don't have the name, but you have every other details on every single case, a positive case and cases that have resulted in death. Now, we agree that we need to keep the data simple, but we believe that it needs to be anchored on open, granular data. And transparency is key, because we can always refer to the data. So I'll show you 3 levels of how we deal with data. This is the most granular. This is the geek level. Not many people go here, but it's important to have the geek level data, because this is your anchor. This is your single source of truth. So anyone challenges you, this is the anchor. So we use this for confidence in terms of vaccine effectiveness. We're very transparent on breakthrough infections, which type of vaccines are showing the greatest breakthrough infections, which type of vaccines are showing the greatest breakthrough deaths. And this has allowed us to build a narrative for why booster doses are necessary. We also upload every single adverse event following immunization because we want to be very clear that there's nothing to hide as far as side effects are concerned. And this is all available on a daily basis. Next. So once you get through the geek level data, which is the granular data, you sort of bring it up slightly. And again, here, we're not dumbing it down too much because we feel that quite a lot of people are quite used to this kind of data. And we put it up in terms of charts every day, in terms of the death, in terms of the people who are ventilated, people who are in ICU. And we use this data to drive the narrative. I mentioned just now, if data is left in a vacuum, then people will start making insights which perhaps are not accurate. So on the right, it's in Malay, but Dr. Mahesh, who is our head of data for the Ministry of Health's crisis response team, he engages on Twitter every day. So here he's explaining claims by anti-vaxxers saying that now the majority of deaths are amongst people who are vaccinated, and therefore the vaccines don't work. Now he's used the data to say that because we have a 90% vaccination coverage of the adult population, then it's logical that most people who are getting infected now are vaccinated. So he's using the data to turn the arguments, which if left in a vacuum, will create an infodemic for us. So it's very important that once you have data, you need to know how to provide the insights in a timely and in a simple manner. Next. And for communications, this next slide will be the most, next slide please. Yeah, so for communication, this is the most front-facing data that we have. So you have the granular data, you have the insights that we debate with on Twitter, on Facebook, but this is the front of the shop, which most people see every day. Now on the left, I wanted to introduce, this is our snapshot on a daily basis. We have this because for the last 1.5 years, everyone has been looking at the top left-hand number, which is active cases and new cases every day. So everyone's obsessed, what is the new case every day? And we realize as we transition towards endemicity, we have to provide slightly more layered details, which doesn't overwhelm people. So if you look at here, it doesn't just tell you how many new cases on the right, which is 6,127, but it tells you recovery. It tells you how many people are in home quarantine, therefore minimal, mild, or no symptoms at all, so 77%. It tells you how many people are on ventilation in ICU. And I keep on telling people the number that we have to look out for, hospitalization, ICU. That's when, of course, the public health system is in danger, and of course, death. So this snapshot has managed to transform people's the framing of the situation from new cases to how bad are the cases and how are we doing in terms of hospitalization capacity. And for vaccinations, we always used to put up this map based on states so that states will sort of compete in a healthy manner to race towards becoming vaccinated. So that's the snapshot of how we communicate our granular data. Next. Now, I want to come to nudging and guiding behavior. So this is, in behavioral science, what's known as social norms. So you create a social norm, and you have people competing and feeling, fear of missing out, FOMO, if you don't adhere to the social norm. So when we started our adolescent vaccination, we wanted to make sure that it was done at the school level, and schools can compete healthily to make sure that most of their students are vaccinated. So on our website, you can actually check every single school in Malaysia and see how many people have been vaccinated. And this has created a healthy social norm adherence to say, my school is 90%, is yours 90%? And this is empowered parents to tell teachers, look, can we get our vaccination program in the schools up and running? So communicating this kind of data, personalized or school level data, has been important in nudging behavior for the adolescent vaccination. Next. This is something else that a lot of people missed, but there was actually a lot of thought that went into this. And this is the behavioral science of plan making. Linking behavior to future moments increases the follow-through of somebody doing that behavior. So this is a very busy slide, but essentially it's actually the SMS that you receive before your vaccination appointment. So we designed the SMS So T minus 3, T minus 12, T minus 14 is when you get your appointment. So everyone's like, oh, I got my appointment. This is great. Now at T minus 3, we want to ensure that the attrition rate is low. So the SMS says, plan your journey to the vaccination center. So we start making the plan making very, very pronounced, so that people start to think about how do I get there, who's going to send me there, and they commit themselves. And on T minus 1, we say, plan your journey, bring your identification card and phones. And because of small prompts like this, we saw attrition rates for appointments very, very low, because people committed to it. Of course, at that point, a lot of people wanted to get vaccinated because the cases were high. But little prompts like this in terms of plan making, communicating the commitment to the appointment was critical. Next. Now, as we move towards endemicity, we have to have mental shortcuts because people just cannot remember what they're supposed to do. For the last 1.5 years, the state has come and swabbed you if there's a cluster in your neighborhood. Now we're moving towards self-testing. Now we're moving towards symptomatic testing. So people don't know what to do. So we've distilled it into TRIS. FTTIS is what the government looks at, but TRIS is what the people look at. And it's very simple. Test if you have COVID symptoms, report your test in the application, isolate immediately if you're positive, inform close contacts, and seek medical help if your condition worsens. S is important because we have had quite a high number of brought-in death cases. And that's simply because health-seeking behavior amongst people who are sick was low for whatever reason. They were scared to come forward. They didn't want to lose out on their jobs or their income, so they ended up staying at home. And then onset of hypoxia, they passed away within 24 to 48 hours. So TRIS has been important as a mantra, as a mental shortcut for us to move away from state swabbing, from the Ministry of Health doing everything, to community empowerment as we move towards endemicity. Next. So that's the brain side of it, and this is the heart of it. This is what we've really, I mean, you cannot replicate strategic communications with just social media and infographics. You have to get boots on the ground. So on the left, Lindung Diri, Lindung Semua is our tagline. This is getting everyone together. What it means is that protect yourself, protect others. That was the tagline of the vaccination program. It meant nobody's safe until everyone is. You vaccinate yourself, you protect others as well. And small things like, you know, the elderly gentleman there going, taking a photograph. He's holding a sign that says, I'm even more handsome now that I've been vaccinated. So a little humor, you know, bring it home. And on the right is, this was how we address vaccine hesitancy through communicating a program on the ground. We did pop-up vaccinations at mosques because we realized that a lot of our Muslim population, conservative population, didn't want the vaccines. But when they saw the imam, the congressional prayer leader being vaccinated, they, of course, were much, much more confident. Next. And these were the images that we used throughout the vaccination campaign, not so much our big vaccination center in urban areas, but this. And this communication we use not just in the rural areas, because we wanted to, we felt that a lot of people in the urban areas had a high level of understanding about the vaccines and were very receptive to vaccinations. But they were concerned about what was happening in the rural areas. Is there vaccine equity within Malaysia? Is there vaccine equity in the rural areas? So we put up a lot of these photographs in our social media, and this related to stories of people in the urban areas saying, my grandmother has been vaccinated in my village. And that created for that community spirit of communicating the benefits of vaccination. So the photos that were most shared were not the mass vaccination centers in the urban areas, but these ones by people in the urban areas, because they're thinking about their grandmother at home. They're thinking about their mother and father in their village. And I think this was key in terms of bringing the program to light. And one thing I wanted to add as well, which is not here, is that we have a large migrant population in Malaysia, people who come to Malaysia to work, and we had vaccination material, information, in, I think, more than 20 languages at the vaccination centers, on social media, because if you cannot speak to them about something as personal as putting something in their bodies, you're not going to succeed. The last couple of slides is actually very important, and that's building trust via personal accountability. On the left, that's me under less than ideal circumstances. That was me apologizing because we opened up the AstraZeneca opt-in program because there were concerns about thrombotic events. So it was an opt-in event where people had to go to the website and register. And of course, the website crashed. And there was great and tremendous anger towards me. And I think it's very important that you own mistakes and you come up and say, sorry, we screwed up. I think you have to weather the opprobrium because otherwise people won't believe you the next time. You have to own the successes and own the mistakes. Otherwise, communication is not going to succeed. And of course, on the right is Dr. Hisham, who's here. He led by example. He was the second person to get jabbed, and he will be receiving his booster jab soon, I hope. Next. And ultimately, public confidence is key to what we do. This is a simple snapshot that we use now, which is high vaccination coverage. We are coming down from the peak of deaths. And images like this speak both to the brain and speaks to the heart as well, because nobody wants to die, especially from COVID. And this drives home the message that we're in this together. Thank you.
Thank you so much, Minister. We didn't discuss this before, but I hope you're okay if we enlist you as a C4H ambassador, because I think you've just you've picked up on pretty much every aspect of the C4H approach in that explanation, so thank you so much. I'm happy now to introduce my excellent WHO colleague, the WHO representative to Malaysia, Dr. Ying Ru Lo. Ying, we've just heard a very impassioned intervention from the Minister about about a whole range of things, including the importance of communicating using data. Can you tell us very briefly how the WHO team in Malaysia has used this approach and why is it so important to our work at country level? Over to you, Ying.
Thank you. Honourable Minister Kari Jamaluddin, Regional Director Dr. Takeshi Kasai, distinguished delegates, good afternoon, good evening. So I just wanted to say that it was really an honor to work with the government of Malaysia during these difficult times. And we have heard already so many examples, great examples, how communication for health was applied in Malaysia. So together we used these data-driven approaches to understand what drives people's behavior, what erodes or strengthens public trust, and how to adjust our strategies as the situation unfolds. So another example was that early on in the pandemic, we commissioned a survey to gauge the knowledge, attitudes, and practices of the population. This revealed at the beginning that COVID-19 was not perceived as a severe disease by nearly 80% of Malaysians, especially among youth, making them less likely to follow the public health advice that would suppress transmission. To address this, we worked together to design an inclusive campaign for young people that was rolled out with partners. This initiative aimed to build an engaged and risk-informed population, went viral, and garnered millions of views online, reaching far beyond our intended audience. When we surveyed the population 6 months later, 99% of people, 99% now said they perceived COVID-19 as a dangerous virus. So as the pandemic progressed and evolved, so did our challenges. We also use dynamic and two-way social listening systems to understand the audience's evolving needs and concerns, addressing pandemic fatigue and adherence to public health and social measures, as well as vaccine hesitancy. So at this point, it's quite clear that we will need to learn how to live with COVID-19 and continue to manage uncertainties. We must therefore ensure we have an informed population that practices a healthy lifestyle, reduces their risk of contracting COVID-19 and is fully immunized. And this can only be accomplished if we continue to listen with empathy and care and engage with communities while making sure that their needs, concerns, cultural and social and other influences are reflected when designing interventions to protect their health. Thank you.
Thanks so much, Ying, for that, and again, the Minister, for that I think that was really a masterclass in the C4H approach from Malaysia, so thank you very, very much. And obviously we look forward to continuing to work with you, with the Malaysian Ministry of Health and the WHO country team on these issues. So we now turn to very different country, very different set of issues, very different aspect of the C4H approach, and that is Papua New Guinea, where we've been working with the National Department of Health and partners to apply the C4H approach to improving maternal and newborn health through the use of storytelling. So we'll hear from the PNG Minister who's online in a moment, as well as our acting WHO rep. But first we'd like to show you the trailer for a television series that we have, television and radio series that we've produced together. It's called It Takes a Village. Let's play the clip now, please.
Hello, girls.
Girls, don't tire out Papa. He needs all his energy for training.
What about this one, huh? It's gonna be a boy this time, huh? Sam, I'm open. I think I can score. Try.
Last one.
Who's laughing now, huh, kids?
Rex! Rex! Miriam had a baby boy.
A little boy. I'm an auntie again. Rex will be so happy.
What's wrong?
Pilum Lapikinine is not coming. Miriam needs another woman.
Rex, Miriam is very weak. If the baby's rubbish does not come out soon, she will start bleeding. She needs the health center.
Miriam needs my help. So do we. You'll be fine.
Good luck, Rex. Where's Rex?
I don't think he's playing today, Chief. Miriam's sick.
Rex! Brother, get down!
She's a woman. Take her and her too. Wake up, wake up.
Please, she's my wife.
Wake up.
Thank you, bro. You're a good man.
Over and out.
What did they say?
He must fly in from Manutau. He'll be very early in the morning.
Hotel Oscar Romeo, good morning on 124.1.
Miriam needs you. Miriam needs you now. Come quick.
Rex!
It's the doctor. It's the doctor.
Dr. Berry! Dr. Berry!
Everything's changed. But I feel like nothing's changed.
Unfortunately, we don't have time to show you the full-length TV episode today, but I think you can see just from that couple of minutes how powerful a piece of communication that is. To tell us more about It Takes a Village, how it came about, why this approach matters so much in PNG, we're very lucky to be joined today, as I mentioned before, by the Honourable Jelta Wong, PNG's Minister for Health. Minister Wong, over to you.
Thank you, Dr. Angela Pratt, and Regional Director, Dr. Kasai, Acting WHO Representative, Ms. Malson, distinguished delegates. It gives me great pleasure to join you all virtually for this event and to speak about our work in the area of C4H, which is the Communication for Health and Maternal and Newborn Health. Let me begin with some facts. Papua New Guinea has one of the highest maternal and newborn mortality ratios in the Western Pacific region. For every 100,000 live births, 171 mothers die. And out of every 1,000 live births, 20 newborns die. Every single death is a tragedy. a tragedy that could have been prevented or treated if the majority of our people had sufficient knowledge about family planning, contraception, and sought help early for antenatal care and supervised delivery. We would be far better off. As a father and a husband, each of these deaths weigh heavily on me. One of the reasons why I couldn't leave my country at this time and join you in Kansai is because our country is going through a surge at the moment with COVID-19. But together with WHO and partners THOR, the Hands of Rescue, and Screencraft, we knew that we needed to strengthen our existing efforts with a new approach. We recognized that alongside investments to strengthen health system capacity and access, we also needed a community-oriented approach, something that would address important social and behavioral drivers to the issue. This includes things like awareness of family planning and knowing when and how to access appropriate antenatal care and supervised birth delivery. It also includes responding to community attitudes around maternal health and health-seeking behavior. The It Takes a Village project is a television and radio program developed to target these factors. We needed to reach both men and women, not just with the right information, but in a manner that would engage and persuade them to get help whenever they needed it. With the support of WHO, evaluation was done, and around the pilot episode to see if we achieved these objectives, I'm very pleased and honored to say that we saw some very promising results. Following this success, we plan to expand the series with the support of the Australian government, creating new episodes that include themes of COVID-19 and COVID-19 vaccines. We thank you for this opportunity to speak on our work in PNG and how we've used entertainment and storytelling to reach, engage, and change attitudes around a very important topic such as maternal and child health. God bless you all.
Thank you so much, Minister Wong, especially for those remarks, but also for making the time to join us this week. We know the situation in PNG is very challenging at the moment, so we really, really appreciate you being here. Now, I'm very happy to introduce another excellent WHO colleague, Anna Malson, who's our acting WHO representative in PNG. Anna, as we've just seen in the trailer and heard from the Minister, that It Takes a Village, the television series, is not a traditional piece of public health communications. It's not a traditional awareness campaign. Can you tell us a little bit more about why WHO in PNG felt like a television series was the right approach? And can you share with us any of the results from that work so far?
Thank you for the question, Dr. Pratt. It's a great pleasure to be connected to this important event alongside the Honourable Minister Wong, Regional Director Dr. Kasai, and distinguished delegates and colleagues. Thank you for this opportunity to speak on It Takes a Village project in Papua New Guinea. As we heard, the project stemmed from the need to address high maternal and newborn mortality rates in PNG. When developing It Takes a Village, we wanted to better understand and address the underlying individual, social, cultural, and environmental influences to low utilisation of healthcare before and during after pregnancy, and deliver it in a manner that would engage and resonate with the community. We knew there was low knowledge on maternal health, misinformation around family planning, and factors related to traditional cultures and gender norms in families and communities. The program therefore sought to directly address these factors. It also gave a platform to the community voice, telling a story that so many could identify with. As Minister Wong mentioned, an important part of this project was the evaluation of the program. We screened the pilot episode separately to a group of men and a group of women from different parts of Papua New Guinea, and they answered the questions before and after viewing. Through these viewing panels, we saw that the program was able to generate a shift in participants' understanding and prioritization of maternal health, as well as their planned behaviors. Men spoke of the specific actions they would take to support women, and women acknowledged the importance of male support. The program challenged entrenched gendered norms around maternal health. Men acknowledged the role of cultural norms in society and spoke of themselves as advocates who will influence change in their communities so that women and newborns have better health outcomes. These viewing panels gave us great insights, and we're using the lessons to inform forthcoming episodes in the series. I'd really like to thank the National Department of Health for their utmost support for the program, as well as the partners, the Hands of Rescue, Screencraft, and the Australian government for making it possible. Thank you, Angela.
Thanks so much, Anna, and again, thanks, Minister Wong, for that brilliant example of the power of storytelling in changing hearts and minds. We've heard a couple of times in this session already how important that is. So this is a great segue to the last piece of work that we'd like to share with you today, which is our regional series called People of the Western Pacific. You might have seen some of these episodes of the People of the Western Pacific series playing during the breaks in our session at different points of the week. When Dr. Kasai began his term as RD almost 3 years ago, he used to challenge all of us, actually he still does challenge all of us, with this question. How well do you know the people that you serve? Whenever he visits a country office, he'll ask the country office staff, how well do you know the people that you serve? The series that we are about to show you one example of was in part inspired by that challenge. It tells the stories of real people from across the region, with the aim of putting a human face on complex health issues, generating understanding and empathy for the people that experience those issues. So to give you a taste of this series, we'd like to share with you now the story of Gansengel, who is a doctor from Mongolia. And then after that, we're going to ask you a couple of questions about how the story made you feel. Let's see Gansengel's story now, please.
Анхны үүрэг гүйцэтгэх хугацаанд би өөрийн гар дээр эмийг алдлаа. Анх бүрөөхтэй Гансенгел гэдэг цэргийн төвөмлөгийн эрчим тэмцэлгээний ихэмж дэслэг цалтай. Манай аймаа тийм биеийн байдал нь жоохон доктортой гайгүй байх үедээ би сайн байна. Одоо гэртээ гарна. Миний хөө мундаг сайн ажиллаж ийн гэж амьдралынхаа эцсийн мөч хүртэл бас тэмцэжсэн явдал доорлоод татсан санагддаг. Саяны сүүлийн үүрэг гүйцэтгэлтэй нэг өдрийн дотор нэг цагийн дотор 3 хүнээс иржсэн тохиолдол гарсан. Бид бүхний нүдэнд бол тэр 3 хүний ар гэрийнхэн бүр хүүхдүүд нь ач зээнэр нь л ер нь бидний нүдэнд харагддаг. Яаж ар гэрт надад би юм байдал нь ийм байсан, одоо ийм болоод өнгөрчлөө гэдэг юм уу, тэр талаар мэдээлэл дуулах их хэцүү. Тэгээд одоо үүрэг гүйцэтгэж явах үедээ тэр нь бол одоо миний эмээгээс өрцөхгүй, миний өвөөгөөс өрцөхгүй гэж ер нь бол миний ойр дотны хүн шиг л одоо бүх хүмүүс харагддаг учраас тэдний хаймнасыг нь аврахын тулд бид бүхэн ер нь өдөр шөнөг бол өөрийгөө гүйцэтгээд өргөсөн тагарахтай хүнчээр зүтгэж явж байна. Хүмүүсийн ер нь биеийн байдал сайжраад эмнэлгээс гараад хөл дээрээ бусаад гарч исэн тохиолдолд бол зөндөө байгаа. Тэр хүмүүсийн гарахтаа баярлаа гэж хэлж байгаа үг нь ер нь одоо л миний сэтгэл санаанд их тод идэг. Дуртай газар их юм бол зайсан толгой дээр нар жаргах цагаар гарч хотын байдлыг харах. Зайсан толгой дээр гараад зогсоход нэг сэтгэл уужраад уушиг тэлэгдээд ингээл дотроосоо их тайвширлыг илэрдэг. Хөл хорооны байдалтай холбоотойгоор л манай найзууд сүүлийн хэдэн сар ер нь уулзлах байгаа. Тэгээд бид бүхэн одоо хоорондоо таарах магадлал хомс ер нь байхгүй болсон. Тэгээ одоогоор ингээд 100 гаруй насаар л ингээд гарчаад байгаа. Энэ чигээр ингээд энэ тоон дээр ингээд бариад ингээд зогсоохын тулд ард иргэд хүн бүхэн мэргэжлийн байгууллагаас гарч байгаа тэр заавар зөвлөмж гэдэг юм ийм л заашгүй биелүүлэх шаардлагатай байна. Энэ вакцин гэдэг зүйлтэй хүн болгон л идэвхтэй хамрагдаж сайн гэж хүсэж байна.
With enormous thanks to Gunsengel for sharing his story with us, as well as to the Ministry of Health in Mongolia for working with us to make the telling of that story possible. So as we've mentioned and you've just seen, storytelling is a very important part of the C4H approach, as is measurement, evaluation and learning. So to put both of those things into practice very quickly, we want to end our session today with a very short exercise. And for this, I'm going to hand over to Olivia Law-Davies, WHO's Communications Manager in the Western Pacific region.
Thanks so much, Angela, and thank you very much, everyone. Whether you're in Himeji or connected online, we'd now like you to take out your phone or your tablet or use your browser on your computer to log into a website called menti.com. You can see the URL there, menti.com, and then pop in the code 76694158 that you can see up there on the screen. Once you're on the page and you've entered the code, you can actually start going through and answering your questions. You just answer each question and then tap on submit to get to the next one. You'll see that there are 3 questions. The first asks you to rate on a scale from 1 to 5, where 1 is strongly disagree and 5 is strongly agree, the extent to which you felt absorbed in Gunsengel's story. And the second part is whether you could see things from his perspective. So just take yourself through those questions. The next will ask you to describe, just using one word, how his story made you feel. And the final question asks you to share with us the main message that you took away from Gunsengel's story. So these questions all relate to the mechanisms that underpin effective storytelling: transportation, relatability, and emotion. So we'll just give you another moment to finish responding to the questions, but since time is quite short, we can perhaps start having a look at the responses to the initial question, since I think quite a few of you have already logged into that. So you can see up there on the screen, when we were looking at transportation, we saw that most of you did feel absorbed, very much so, in Gunsengel's story, and that is a measure of the extent to which you focused your cognitive and emotional resources on the story and enabled your brain to bring it to life, for it to transport you. The next question is about relatability, and again, we're seeing high results there, which indicate that most of you put yourself in his shoes and saw events from his perspective. We're wired to do and trust people that we relate to, people that we like, people that we want to be like, or who we feel as if we know. The next question, if we can carry on to the next slide, was about emotion. How did Gunsengel's story make you feel? So we can see a lot of different emotions captured there on the screen. And the biggest one you can see in the center is sad, but there's also inspired, hopeful, relatable, and respect for the work that he's doing. A lot of empathy and also a sense of resilience. Let's go on to the final question now, about the main message that people took away from Gunsengel's story. So we've got a lot of different responses that we can see there on the screen, of course, and I think just looking at some of those, we can look at the appreciation of the role of health workers, resilience despite adversity, the amazing work done by the health workers in all of our countries across the region. And I think this speaks to the power of the story in terms of emotion, relatability, and transportation. And we can conclude that if we did all of that with a story like this, we can expect audiences to take something away from it and do something with the message. So it was a very short exercise, but thanks so much to everybody here in Himeji and online for participating. We hope that you find it encouraging, that it's actually doable to do measurement, evaluation, and learning and use the power of storytelling to improve the power of our communications to change health of our populations. Back to you, Angela.
Thanks so much, Liv. Thanks to everybody who participated in that little mini show not tell exercise, showing the importance of storytelling as well as the importance of using data to inform our communication and learning from what that data tells us. This brings us to the end of our session today. I really want to give a very, very big thanks to everyone who participated, in particular our excellent speakers, Minister Kari, Minister Wong, Ying, Anna. As Dr. Kasai said at the start of this session, communication will become even more important in the future as we respond to a range of complex and evolving health threats. And we really look forward to using the C4H approach in partnership with Ministries of Health to respond to those. If you would like to learn more about C4H, I hope we've inspired or sparked some interest. If you're here in Himeji, take a look at this brochure, which should be sitting on all of your seats. You can also go to our website, where you can find that brochure, as well as stories, information, including about all of the examples that we've spoken about today. So we hope that this session has given you a better understanding of what we mean by C4H, a sense of where we are in our journey to scale up our work on C4H, and how we can use it to make measurable contributions to improving public health. And obviously, we look forward to continuing to work with all of you as we scale up the approach towards helping to make our region the healthiest and safest region in the world. Thank you so much.